I started out with young ladies and delivering babies, and my patient population's kind of aged with me, and now probably about 75% of my population are actually postmenopausal, and I spend majority of my time doing postmenopausal medicine. I don't deliver babies anymore, and stopped that about 10 years ago. I just do office-based GYN now. A lot of guys here, so you know what we ought to arrange, Andrea, is a andropause talk, and the women are going to have to come with the guys. It's the guys are coming with the women. Basically, what we're going to do, I've got a few slides, but I'm going to mainly use the slides kind of as talking points, and hopefully remind me of what I need to mention. And we're going to talk a little bit about menopause and about hormone replacement therapy, and hopefully we will. There's a lot of misinformation out, particularly about hormone replacement. Hopefully we can clarify some of that and dispel some of the myths. Menopause, what is that? That's basically cessation of ovarian function. It's when your ovaries quit making hormones. A natural menopause is where a lady's ovaries just naturally stop making hormones, and that happens between age 45 and 55. The top of that bell curve is between 50 and 51. You can have a surgical menopause, which is where the ovaries are removed at the time of surgery. So basically I have a surgical menopause and natural menopause, and we're going to kind of be, when we're talking about hormone replacement and issues with menopause, we're kind of grouping both of those together, because you manage a surgical menopause very similar to how you manage a natural menopause. This is pretty high-tech stuff, but maybe we can, and I'm going to go really quickly through a lot of these, or we'll be here all afternoon. Basically, you're considered postmenopausal once you've been a full year without a menstrual period. And I mentioned earlier, it's 45 to 55. That's called the perimenopause, P-E-R-I, around the menopause. And that's when you start sort of skipping around with your menstrual cycles. So you're not actually officially considered postmenopausal until you've been a full year without having a menstrual period. As I mentioned earlier, at the top of that bell curve, average menopause is 51. Let's see, this just tells you there's a lot of folks that are perimenopausal and subsequently will be menopausal. Today, a woman's life expectancy is 80.5 years, and as you ladies know, your life expectancy is a little higher than the guys. The guys are about 77. So, you know, you're spending about a third of your life in the menopause. So that's a significant amount of time. Main issues that you see with the menopause, vasomotor symptoms, those hot flashes and night sweats. You can have some vaginal issues, that's vaginal dryness, discomfort with intercourse. You can have some sleep issues. In fact, probably the first sign of your estrogen levels dropping is you don't sleep well. You don't get in stage 4 REM sleep. So a lot of ladies, that's their first complaint, they're not sleeping well. And you can have some urinary issues, particularly urge incontinence or overactive bladder. And that's where you're having to get up multiple times at night to go to the bathroom, or during the day, you all of a sudden your brain gets this signal that you need to go, and it's like, man, I got to find the ladies' room in a hurry. There's some other issues also with menopause. There's some cognitive or mental type issues, and nobody's ever really proven whether there's increase or decrease dementia such as Alzheimer's relative to estrogen, but we do know a lot of ladies complain they just don't feel like they think clearly. They've just sort of got this mental fog, and that's a quite common complaint that folks have. Again, we're going to slip through a lot of these quickly. If you go through menopause before age 40, that's considered premature menopause. You know, to be politically correct, we used to call it premature ovarian failure. Now it's called ovarian insufficiency. So I guess insufficiency is supposed to be a better politically correct term than perimenopause. Some people can have fairly significant acute changes. You know, I mean, just wake up one day and they're having all sorts of problems, and then some people it just slowly creeps up on you. All right, vasomotor symptoms. That's the hot flashes and night sweats. That's in a lady where you get this flushing sensation. You feel like you're just on fire. It usually starts in the head and goes down into the chest. And that lasts anywhere from about 30 seconds to 3 minutes. If you have somebody who says, well, I'm just hot all the time, that's just kind of your thermostat getting reset as part of the aging process. An actual hot flash only lasts 30 seconds to 3 minutes, but it can be quite uncomfortable. A night sweat is where you actually wake up from a deep sleep, and usually your pajamas are moist. You've actually been sweating. So those are vasomotor symptoms. Some folks don't have any going through the menopause. Some folks have them and they spontaneously stop, and some folks have them forever. And that's why I have a whole bunch of older ladies that are on hormone replacement, because if you stop them, they're absolutely miserable. You know, we still don't know about cognitive changes. I mentioned earlier about is an increased instance of dementia, and particularly Alzheimer's, with estrogen deficiency, and we don't know that. There's some studies that show that there's a worsening, and some studies show that there's an improvement. Depression, anxiety. It's not proven that you had increased risk of depression and anxiety. As we all age, there's a higher instance of depression and anxiety, but it's probably age-related and not hormone-related. What's also thought to probably be related to that is the fact that, you know, as you get older, you're aging, you're losing fertility, you're already going to have sleep problems, you got increased medical problems, hypertension, thyroid disease, etc. Kids have grown up and gone, and maybe you know, you're looking towards retirement, or you're sort of having to retire when maybe you're not ready to retire. So there's a lot of other issues that come along about the time of the menopause that's not necessarily associated with decreased hormones. One of the main issues we have besides hot flashes and night sweats is what we call vulvovaginal symptoms, and that basically just means vaginal dryness in the tissues outside the vagina, and that's just a normal aging process. Once a lady is no longer making estrogen, and if she's not taking estrogen, she's going to have vaginal dryness and discomfort. It's just an aging process. And we'll talk in a little bit about how we treat that. A lot has changed in the last 12 years on how we treat that. What about urinary complaints? The only thing that's really actually been tagged to decreased estrogen is maybe overactive bladder. Urinary stress incontinence is not related to your hormone status. Recurrent urinary tract infections are. If you have a lady that keeps having repetitive urinary tract infections, if you get her on some vaginal estrogen, you can pretty much get a handle on that, at least reduce the number. And that's because you have estrogen receptors in the base of the bladder. And as we all know, the bladder basically sits on top of the vagina. So if you're stimulating the estrogen receptors in the vaginal tissues, you also stimulate them in the urinary tissues. All right, what about sexual issues? Well, you know, with age, you have decreased libido or sex drive. And generally speaking, unless the ladies are married to a much younger guy, the guy's going through the same thing, so it's usually not that big of an issue. As I mentioned earlier, with the loss of estrogen, you start losing vaginal moisture and elasticity, and we'll initially treat that with just moisturizers and lubricants, but at some point most people will progress to requiring local estrogen therapy, which is an estrogen cream or tablet or estrogen ring. Interestingly, we'll get into this hopefully with the hormone part. A lot of women aren't aware. They actually make a fair amount of androgens, which is male hormone, testosterone. The ovaries make about half, and the adrenal gland makes about half. And so with the menopause, you lose a significant amount from the ovaries, and that also accounts for a decreased libido, sexual desire, arousal, vaginal lubrication, as does the estrogen component. Talking about just hormone effects on sexual function, improves desire, dryness, discomfort. You're sleeping better, so you're less fatigued. You feel better if you get a good night's sleep. Estrogen also helps prevent collagen breakdown, loss of skin elasticity, you know, the aging process. And what about testosterone? Also helps with libido, sexual desire. It's definitely helps on our ladies with their bone density and preventing osteoporosis and bone thinning. Testosterone is an anabolic steroid, so women taking testosterone just feel better. They just have a better sense of well-being. We'll talk about that later. In this country, we don't have any FDA-approved testosterone therapy for females. So either they have to use some of their husband's testosterone in a much lower dose, or we prescribe testosterone, what we call off-label, for non-FDA indication. What about cardiovascular issues in menopause? And we're going to get to the hormone replacement, I promise you. First off, cardiovascular disease accounts for more deaths in females than all the cancers combined. And if you ask most females what you're most afraid of dying from, they're going to say probably breast cancer is number one. Still heart disease is the number one cause of death in the female population. It's also the number one cause of death in the male. And in fact, as I mentioned, more deaths from cardiovascular disease than all your cancers combined. And we'll talk about the hormone replacement and cardiovascular disease when we get into the hormone part. Everybody needs to know this. What are heart disease modifiable risk factors? What can you do to improve your chances of developing heart disease? You can stop smoking, you can try to maintain a normal weight, you can be active. You know, it's easier said than done, try to get rid of stress, but you try to do that. You treat high blood pressure. Dyslipidemia is elevated cholesterol. You treat that. You treat diabetes, diet, medication, and you got modifiable factors that we can all do something about. You got non-modifiable such as age, basically family history, and menopause. Just very briefly, osteoporosis, both men and women have to worry about that. That's basically where you start losing bone density or mineral calcification from your bones, makes your bones more brittle. You end up falling down the back steps and end up fracturing the hip when otherwise you'd just, you know, hurt your pride and maybe bruised your hip. And estrogen therapy actually one of the indications is prevention of osteoporosis, particularly in people that cannot take the osteoporosis medications because of having side effects. Diabetes mellitus, estrogen actually helps decrease insulin insensitivity. Women premenopausally have less diabetes. Postmenopausal women on estrogen replacement have less diabetes. All right, so what cancer do people worry about? What do women worry about? What about breast cancer, right? All right, well, you know, unfortunately, the press grabs on the topics and many times gets things a little bit confused. And we'll touch on this, I think, on the second slide set too. Estrogen does not cause breast cancer. It's not an initiator, it's an accelerator. It's like if you're trying to light your barbecue pit, the estrogen is lighter fluid, okay? You're not going to get that charcoal lit without a match. Estrogen's the lighter fluid. It's the accelerator, but not the initiator. And that's really confusing with folks. In fact, in the Women's Health Initiative study, which came out in 2002, which pretty much turned hormone replacement therapy on its ears, that was the first indication that combined estrogen with a synthetic progesterone actually slightly increased the risk of breast cancer. Estrogen only, which we use in ladies that don't have a uterus, actually there was a decreased risk. The actual Women's Health Initiative study was done looking at improvement in cardiovascular disease, and we'll touch on that in just a sec. But I'm here to tell you that breast cancer is not a reason not to do hormone replacement if you need it. Now, we all have acquaintances that have had breast cancer and they can't take estrogen, not because it causes it, but because the oncologists do not want the estrogen to increase the chance of a recurrence. In other words, if whatever therapy you had, be it mastectomy, lumpectomy, radiation, chemotherapy, didn't get rid of every single breast cancer cell, you don't want something to stimulate any residual cancer. So that's why folks that have had breast cancer are not candidates for estrogen replacement therapy. Again, it's an accelerator, not an initiator. All right, we're going to get through this because I don't want to put anybody say, "Oh man, we're finally getting to hormone replacement therapy." This is a little bit confusing. So when you read stuff in the newspaper and magazines, you know, that's one reason everything is so confusing. Estrogen by itself is considered estrogen therapy. And again, the ladies that are candidates for estrogen therapy are ladies that don't have a uterus. Now, why is that? Because estrogen stimulates the growth of the lining of the uterus, and it can actually make that lining of the uterus develop into endometrial cancer. Not breast cancer, but endometrial, which is cancer of the uterus. So you have to add, you'll see the red button? All right, see this thing says progestogen therapy? You have to add some type of progestogen to estrogen if you still have your uterus. And what makes that even more confusing is that a progestin is a synthetic progesterone, and that increases the risk of breast cancer. 1 breast cancer per 1,000 women on estrogen progestin. Natural progesterone has not been shown to increase the risk of breast cancer. Then, you know, we're all saying, what is bioidentical hormones? That is not actually a medical term. That's a marketing term. And basically, a lot of medical folks have picked up on it now. Bioidentical means it's chemically identical to what your ovaries were making. Now, you basically get your bioidentical hormone therapies from compounding pharmacists, and unfortunately and I use compounding pharmacists because that's predominantly how I get my ladies' testosterone. But anyway, some compounding pharmacists not around here want patients to think because it's bioidentical it's safer. No, we got 75% of our estrogen products that are commercially available are bioidentical. We only have a few that are not. We've got one that comes from pregnant horses' urine. That's called Premarin. Stands for pregnant mare's urine. And then, but the majority is 17-beta estradiol, which are identical to what your ovaries make. And that actually is a plant source. Comes from soybeans and corn, believe it or not. Natural progesterone comes from the Mexican wild yam. So obviously some chemical processing is done. You're not just squeezing a yam and getting progesterone, but bioidentical, don't think that there's any difference relative to safety and side effects and so forth and so on. There's really not. And there's a lot of misinformation out there. Basically, we have FDA approves oral estrogen in transdermal and vaginal. Oral is self-explanatory. You swallow it. Transdermal is through the skin. Vaginal is through the vagina. Now, there are other ways to get estrogen that aren't FDA approved. There's injections, and the pellets. There are troches, little things that you put under your tongue that dissolve, and those are pretty much done by compounding pharmacists. Let's see. Vasomotor symptoms. We talked about hot flashes and night sweats. Most effective treatment is hormone replacement. We now have, and the most effective treatment for vaginal dryness, hormone replacement. We now have oral estrogen you swallow goes through, everything you take by mouth goes through the liver to get where it's going. Your liver makes your clotting factors. So oral estrogen actually increases your risk of blood clots. And that's the main downside to estrogen replacement therapy. It's not breast cancer. I tell ladies actually the downside is to your pocketbook, because in my postmenopausal population I don't prescribe oral estrogen. I have folks use transdermal, meaning through the skin. You get a little more consistent levels, and I'm not increasing the thrombotic risk or the risk of blood clots and deep vein thrombosis. We'll touch on that, I think, on this next set. We already talked about estrogen therapy and breast cancer. Just to reiterate, there's a slight increased risk with estrogen and a synthetic progesterone. There is a slight decreased risk with estrogen only. And we have not found that there is a increased risk with estrogen and natural progesterone. So the take-home message is, if you don't have a uterus and you take an estrogen, you're not at any increased risk of breast cancer, and you probably at a slight decreased risk. If you do have a uterus and you take an estrogen and therefore you need some type of progestational medicine, you want to take natural progesterone, which is commercially available in the form of something called prometrium. You don't want to take a synthetic, which is medroxyprogesterone acetate or norethindrone. Alternatives. And we're going to get into hormone, I promise you we're going to get into hormone replacement before I put everybody to sleep in just a second. But what are the alternatives? For years we've been using alternatives to treat hot flashes and night sweats for people that were not candidates for estrogen or didn't want to take estrogen. They were all what we call off-label. Doesn't mean not safe, it just means not FDA approved. And we've been using SSRIs, which are like Prozac, Celexa, Zoloft. Actually, in the last year, a medicine called Brazil has come on the market, which is basically Paxil. So we actually now even have an FDA-approved non-hormonal treatment for vasomotor. And in these SNRIs, venlafaxine is Effexor, and that's, I forget which one that is. Then been using kind of sedative-type medicines. Gabapentin is an anticonvulsant. Clonidines for blood pressure. And those have helped in some folks that you don't really have a choice. Just very quickly, your herbal medications have not been shown to do any better than placebo. Now, every medicine has a 30% placebo effect. So if you say, man, I'm taking black cohosh, it helps my hot flashes wonderfully, that's great, you know? And who cares if it's placebo effect or real, if it's working and it's not causing you any harm. But none of the herbal medicine has been shown to make a whole lot of difference. You know, there's some things you can do, behavior modification for vasomotor symptoms. Menopause is when a lady's ovaries quit functioning, that's natural menopause. Surgical menopause is when we remove the ovaries at the time of surgery, such as when you're doing a hysterectomy. If you have your ovaries removed prior to the average age of menopause, which is 50 to 51, it's a no-brainer. You want hormone replacement therapy till at least you get to the age that you go through the natural menopause. Female hormones do other things other than just prevent hot flashes, night sweats, and help prevent vaginal dryness. They do things we're not even aware of. There is helps with slowing the loss of collagen, skin elasticity, bone thinning, and then I definitely wanted to touch on this cardiovascular issue. Ladies that, well, first off, women prior to the menopause have less heart disease than men. I mean, that's gone on forever. And so we've known forever that there must be something about estrogen that is protecting women, because a 45-year-old woman who's still having a menstrual period is at about a fifth or tenth the risk of a 45-year-old man with heart disease. Once a lady, however, is menopausal, her heart disease risk equals a male. So there's something about estrogen that prevents heart disease. What we actually found out with the Women's Health Initiative that came out in 2002, and again that study was actually designed to look at estrogen and cardiovascular disease, not to look at hot flashes or bone density or breast cancer or any of these other things. And what we found out is that if a lady is never estrogen depleted, if you put her on estrogen replacement therapy at the time that her ovarian function ceases, either naturally or because you removed her ovaries at the time of a hysterectomy, then her heart disease risk is about half of a lady that's not on estrogen. Now you got to do it immediately, because if you've been off estrogen about 10 years or greater, your heart disease risk is the same. And then you start it, your heart disease risk is the same. In fact, if you've been menopausal for 10 years and you start estrogen, you actually have a slight increased risk the first year you're on estrogen therapy of having a cardiac event. So it's been shown that estrogen actually is protective for heart disease, and it's thought because it allows vasodilatation of the blood vessels, and so you get easier blood flow, heart doesn't have to work as hard, less risk of hypertension. I don't think we're sure how estrogen therapy helps reduce the risk of diabetes, but it has been shown that it plays a role in estrogen or insulin insensitivity. So basically, we know the menopause is 50 to 51 on average. We know that's when the ovarian function ceases. So what's the indications for estrogen? Well, it used to be we'd encourage most all of our ladies that were menopausal go on estrogen therapy. Now we basically pick and choose. If you don't have vasomotor symptoms, you don't have mood swings, you don't have sleep disturbances, we don't put you on estrogen therapy. If you have any of those, we do. The second indication, and this comes from American College OB/GYN and North American Menopause Society, that's at NAMS. Those are kind of the gurus in postmenopausal medicine. The second indication is bone thinning that does not respond to your medications like Fosamax, Actonel, Beniva. Those are called bisphosphonates. That's the second indication. And then the third indication is vulvovaginal issues that don't respond to what we call local therapy. Local therapy is where we use an estrogen vaginal cream, suppository, or vaginal ring. Systemic therapy is where you take something transdermally and it's treating the whole body. So those are indications: vasomotor, bone density, vulvovaginal that does not respond to to local therapy. Now, I probably got just as many women that want to be on hormone replacement therapy that don't necessarily have issues with that. It's because they just feel better. You have a better sense of well-being. And that's been shown. Quality of life, QOL. Y'all have probably seen that in some of these talks. Quality of life seems to be better with estrogen therapy. People just feel better. And so as long as, so we do, something called informed consent, as long as folks understand potential risk, then if they decide that the benefits of how they feel outweigh their risk, then I put people on hormone replacement therapy. And as I mentioned, for most people, the main risk is to your pocketbook, because none of this stuff is cheap. They don't give any of it away, even the generics. So if we can negate the thrombotic risk by not doing oral and doing transdermal, and we can negate the slight increased risk in breast cancer by using a natural progesterone and not a synthetic, then the risk is really to the pocketbook. So those are basically the indications, and I'm going to try to leave some time. I'm not going to go through this other set, Andrew. We'll be here all afternoon. So I'm going to try to leave a little time if anybody's got any questions.